Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This Journal of Clinical Oncology podcast provides observations, commentary on a JCO article, Recurrence and Survival after randomization to laparoscopy versus laparotomy for comprehensive surgical staging of uterine cancer in the Gynecologic Oncology Group Lap2 trial by Joan L. Walker and colleagues. My name is Karine Kreutzberg, and I'm a senior radiation oncologist at Leiden University Medical Center and associate professor at Leiden University, the Netherlands. I'm a radiation oncologist specializing in the research and treatment of gynecological cancers, especially uterine cancer. The title of my podcast is Recurrence and Survival Results of the GOG Lap2 trial confirm safety of the laparoscopic approach to surgical staging and treatment for uterine cancer. The Lap2 trial was designed and coordinated by the Gynecological Oncology Group to evaluate the safety and side effects of laparoscopy compared to laparotomy for surgical staging and treatment of patients with clinical stage 1 or 2 uterine cancer. Originally, comparison of short-term morbidity and mortality and quality of life had been the primary objectives of the trial. But due to concerns regarding potential inferior staging and more procedure-related recurrences with laparoscopy, the study was amended to also assess non-inferiority of the recurrence rates between the two treatments. 2,616 patients were recruited to this multi-center trial between 1996 and 2005 and were randomly allocated 2-to-1 to either laparoscopy or laparotomy for the performance of hysterectomy, salpingo-oophorectomy, pelvic cytology, pelvic and para-aortic lymphadenectomy for full surgical staging and treatment. In a previous analysis published in the GCO in 2009, the perioperative morbidity and mortality and short-term quality of life after laparoscopy were reported to be superior to laparotomy. Patients who had laparoscopy had a shorter hospital stay, fewer moderate to severe postoperative adverse events, 14 versus 21%, and improved body image. While pelvic and para-aortic lymph nodes were not removed in 8 versus 4%, there were no significant differences in final tumor stage or identification of metastatic disease. The main primary objective of the Lap2 recurrence and survival analysis was to establish non-inferiority of laparoscopy, and the primary endpoint was non-inferiority of the recurrence-free interval, defined as a hazard ratio of 1.4 for laparoscopy relative to laparotomy, excluding more than a 40% increase with sufficient precision. The total required number of recurrences for the final analysis was 384, based on the expected recurrence rate of 15% in the laparotomy arm. The current analysis was done at a median follow-up duration of 59 months. The estimated hazard ratio for laparoscopy relative to laparotomy was 1.14, with a 95% upper bound at 1.46, just falling short of the protocol-specified definition of non-inferiority. However, the actual recurrence rates were lower than anticipated, with estimated 3-year recurrence rates of 11.4% in the laparoscopy group and 10.2% after laparotomy, for a total of 309 events. It was deemed unlikely that the targeted number of events, 384, would be reached even with extensive additional follow-up. Therefore, an unscheduled interim analysis was performed and presented to the Data Monitoring Committee, which approved final analysis and the release of the clinical trial results. Although the predefined statistical boundary for non-inferiority was just not reached, primarily due to lower than expected recurrence rates, The estimated absolute difference in 3-year recurrence rate was only 1.14%, which can well be considered sufficiently low and precise to conclude that this important large trial has established the clinical efficacy and safety of laparoscopy for uterine cancer. Estimated 5-year overall survival was 84.8% on both arms. Sites of first recurrence and use of postoperative adjuvant therapy in 31% of patients were similar in the two treatment arms. Potential trocar recurrences were found in 4 patients for an incidence rate of only 0.24%, and 3 of those 4 were noted in patients with advanced disease. Multivariable analysis confirmed age, surgical stage, cell type, myometrial invasion, and lymphatic vascular space involvement to influence recurrence. The results of the largest clinical trial of laparoscopy are of clear benefit for many patients internationally. Uterine cancer is common, with 43,470 cases and 7,950 deaths in the United States projected for 2011, and primarily affects postmenopausal women of 60 years of age with frequent comorbidities. Establishing safety of a less invasive surgical approach with proven reduced short-term side effects, more rapid recovery, and better post-operative quality of life is a major contribution to the clinical care of patients with this common cancer. Surgery is the cornerstone of treatment for uterine cancer and consists of total extrafacial hysterectomy and bilateral salpingo oophorectomy. Surgical staging of the pelvic and lower periaortic lymph nodes and peritoneal cytology are done to determine potential microscopic spread and establish final tumor stage according to International Federation of Gynecologic and Obstetrics staging system. Adjuvant treatment, including external beam radiation therapy, vaginal brachytherapy, and/or chemotherapy, is based on risk factors such as histological cell type, grade, depth of myometrial invasion, lymphavascular space invasion, and stage, in order to avoid overtreatment with associated toxicities. Lymphavascular space invasion has been shown to be associated with microscopic pelvic nodal metastasis, but also with increased risk of recurrence in absence of nodal spread, and such risk factors determine final outcome. 2 previous randomized trials of surgery with or without lymphadenectomy, the UK Aztec trial and the Italian trial, have not shown any survival benefit of lymphadenectomy for clinical stage 1 endometrial cancer, and the 5-year overall survival rate of 85% in the Lap2 trial is very much in line with other randomized trials with similar patient groups but without lymphadenectomy or with lymphadenectomy in only a minority of cases, such as the Aztec radiotherapy trial, the Portec 1 and 2 trials, and the NSGO trial. In the Lap2 trial, 70% of patients had early-stage disease with no or superficial myometrial invasion. It could have been considered to close the Lap2 trial for such low-risk disease cases and continuing randomizing patients with risk factors such as deep myometrial invasion, grade 3 or stage 2 disease to reach the required number of events and also to establish the safety of laparoscopy in patients with these risk factors. It would be relevant to perform an additional analysis of the Lap2 results for patients with grade 3 disease. 2 other randomized trials have compared laparoscopy to laparotomy for early-stage endometrial cancer, but were not powered for non-inferiority analysis. The Australian LACE trial allowed omitting lymphadenectomy for well or moderately differentiated cancers with less than 50% myometrial invasion and for unfit patients and those with morbid obesity. The Dutch trial did not use lymphadenectomy in line with the randomized lymphadenectomy trials. Both of these trials and the Lap2 trial all showed reduced hospital stay and more rapid recovery after laparoscopy. And the Australian and Lap2 trials also showed significantly lower post-operative complication rates and better short-term quality of life, most notably better physical and functional well-being and body image. The Australian and Dutch trials had, however, significantly lower conversion rates than the Lap2 trial, 10.8% in the Dutch trial and 2.4% in the LACE trial, compared to 26% in the Lap2 trial, probably reflecting the requirement of full surgical staging and a higher proportion of morbidly obese patients in the Lap2 trial. Patients in the LACE trial who had lymph node dissections had lower functional well-being and FACT-G summary scores than those without lymph node dissection. The question remains if requirement of full staging justifies conversion to laparotomy in low-risk patients. In summary, the GOG Lap2 trial has established the safety and non-inferiority of laparoscopy for surgical staging and treatment of stage 1 and 2 uterine cancer, providing many women with this common cancer a lower risk of perioperative complications, more rapid recovery, and a better quality of life than with laparotomy. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.